Okay, good afternoon, everybody. Welcome to this Hotline 2 Atrial Fibrillation Pacing session. It's a pleasure for me to co-share this session with Dr. Elliott Antman from Boston, US, and Josep Brugada from Barcelona, Spain. So we will have the presentation of different trials this afternoon. We'll have a discussion that will discuss the results of the trial, and the panel in the podium will also discuss the trial. So because of time, we do not have the possibility to accept questions from the audience. It was also said to me that I have to tell you that please refrain from taking pictures because this is a hotline session with new information. Some of them might be under embargo so far. So let's start with the first presentation, which in fact are two presentations because these are two studies from the same trial. And the first one will be done by Dr. Kobori on efficacy of adenosine triphosphate-guided ablation for atrial fibrillation and masking dormant electrical reconduction by adenosine triphosphate. This is the under ATP trial, and the presenter has now 6 minutes because the 6 other minutes will be by his co-worker on a different study on the same trial.
Thank you, Chairman. Ladies and gentlemen, it's my great honor to present our study in this glorious session. The cancer plus atrial fibrillation trial, Chairpersons trials, is a 2x2 factorial randomized controlled trial to investigate the current issue of catheter ablation for atrial fibrillation. First, I would like to present the under ATP trial, and next, Dr. Kaitani will present the ESC trial. Most of recurrent atrial tachyarrhythmia after pulmonary vein isolation for atrial fibrillation are due to reconnections of pulmonary veins. Adenosine, or ATP, has been reported to provoke dormant conduction after an initially successful PVA. Thus, ATP-guided additional ablation has been proposed as an adjunctive approach to establish permanent pulmonary vein disconnection and thereby decrease recurrences of atrial fibrillation post-ablation. However, only several retrospective studies and one randomized controlled trials with a relatively small number of patients have shown the efficacy of ATP-guided PVA. Therefore, the aim of this large-scale randomized controlled trial was to evaluate the efficacy of ATP-guided PVA as compared with conventional PVA in patients undergoing AF ablation. A total of over 3,700 patients were screened, and finally, 2,113 patients were randomly assigned to ATP-guided PVA or conventional PVA before ablation. One-year follow-up data was available in 90.5% of the patients. We included the patients undergoing their first catheter ablation for atrial fibrillation, and the exclusion criteria as stated below. The standard method of pulmonary vein isolation in the present study was extensive encircling pulmonary vein isolation. After an initially successful pulmonary vein isolation, in patients assigned to ATP-guided PVA, 0.4 milligram per kilogram of ATP was rapidly administered intravenously to unmask dormant conduction. When dormant conduction was provoked, additional ablation were performed until the disappearance of any dormant conductions. The primary endpoint of the study was recurrent atrial tachyarrhythmia at 1 year with a blanking period of 90 days post-ablation. Clinical follow-up was shown here. In result, there are no significant differences in most of patient baseline characteristics. On the other hand, because of a programming error in the randomization system, there were significant differences in age and age-related characteristics. However, procedural characteristics are almost identical between the groups, including supportive devices, highly use of supportive devices for creating durable PBI lesions. After an initially successful PBI, spontaneous PB reconnections were equally observed among the groups, and additional ablation re-isolated the pulmonary veins. A median time from initial success of PB isolation to ATP test was 57 minutes, and dormant conduction was observed in 27.6% of the patients. And a mean of 5 additional ablation completely eliminated dormant conductions in almost all patients. There were no significant increase in any of peri-procedural complications with ATP-guided ablation. This slide shows the Kaplan-Meier curve of event-free rate after AF ablation. The one-year follow-up, one-year event-free rate from the primary endpoint was 68.7% in ATP-guided PBI and 67.1% in conventional PBI with no significant difference. As you can see, there are no significant differences regardless of AF type. This slide shows the pre-specified subgroup analysis regarding the treatment effect of ATP-guided approach on their primary endpoint. There was no significant interaction across all the subgroups. Randomization error is one of the limitations. In spite of these limitations, ladies and gentlemen, we would like to conclude the present study. There was no significant reduction in the incidence of recurrent atrial tachyarrhythmia after catheter ablation of atrial fibrillation with the ATP-guided PBI as compared to the conventional PBI. Thank you for your attention. Next is ESC.
Thank you very much. We move to the second part of this presentation, efficacy of antiarrhythmic drugs short-term use after catheter ablation for AFib, the EAST-AF trial by Dr. Kaitani.
Thank you. I'm very grateful for this opportunity to present our study, EAST-AF trial. I have no disclosure. Let me start with a brief background. Transient atrial tachyarrhythmia following the atrial fibrillation occur frequent in the first few months. A sizable portion of this early recurrence is related to irritability from the ablation procedure. On the other hand, early recurrence is a strong predictor for the later recurrence following the successful PB isolation. Therefore, we hypothesize that 19-day use of anti-arrhythmic drug following the AFib ablation could produce incidence of early recurrence and thereby promote reverse remodeling of left atrium, leading to improve the better long-term clinical outcome. In EAST-AF trial, we randomized the patient after the successful AFib ablation. For the patient assigned to the AD and the control groups. For the patient in the AD group, Williams class 1 or 3 drugs were started from the standard dosage immediately after procedure. 1 year follow-up data was completed in 99.2% patient. We observed atrial tachycardia recurrences at 1 year with blanking period of 90 days as a primary endpoint. Atrial tachyarrhythmia recurrences during the blanking period of 19 days as a secondary endpoint. Baseline patient characteristics are shown in the table. As with the under ATP trial, there were significant differences in the age, gender, age-related variable due to the misprogramming of the randomization regarding the age. Therefore, in this presentation, we will show the adjusted for these age-related stratified variable by Cox proportional hazard model. This shows the medication at discharge. As you can see, except for the class 1 or 3 anti-arrhythmic drugs, there are no significant differences in the use of the medication, including a beta blocker. This pie chart shows the rate of anti-arrhythmic drug used in AD groups. 75 patients received class 1 drugs, 25% received class 3 drugs. This slide shows the arrhythmia-free curves during the blanking period. Significant greater number of patients in control groups reached a secondary endpoint. Arrhythmia-free rate at 90 days, it was 59% in AD group and 52.1% in the control group. Relative risk reduction rate was 14%. Well, if we look at the primary endpoint, however, there were no significant differences at 1 year follow-up between the two groups. This finding is consistent across all the pre-specified subgroups, including the patient subdivided by the type of AF. We also assess the safety of this trial. Regarding the procedure complication, there were no significant differences between the two groups, and the evident side effect of AAD was observed of 4.1% patient without any serious events. In this presentation, I include several limitations, including those associated with the randomization. There might have been the differences in the recommended AD and their dosage between the present study and the Western AF guideline. It's also a limitation. In conclusion, short-term AAD treatment for 19 days following the ablation significantly reduced the atrial tachyarrhythmia recurrence during a treatment period of 19 days. However, it did not lead to improve the clinical outcomes at 1 year follow-up. So I would like to finally express many thanks for all contributors in the 90 centers. Thank you for your attention.
Dr. John Camm will be discussing both studies on the same trial.
Mr. Chairman, ladies and gentlemen, good afternoon. I'm very pleased to discuss these two trials presented by Dr. Kobori and Dr. Kaitani. Let me first of all declare that I may have some interests, although I think none of these specifically apply to this trial. Pulmonary vein isolation is the so-called cornerstone of ablation therapy for atrial fibrillation. And yet, in the following days, weeks, and months, there is a high recurrence of atrial tachyarrhythmias, usually attributed to inflammation, delayed maturation of ablation lesions, and to some extent high catecholamine status. And yet, these early tachyarrhythmias do predict the occurrence of late arrhythmias. For example, in this study, patients with an early relapse had a response to atrial fibrillation in 1/4 of cases, and those without had a response to long-onset atrial fibrillation in a high proportion. Despite this, delayed recurrences of atrial tachyarrhythmias are attributed to various mechanisms, the most popular being gaps in the encircling ablation lesion. But also there is the issue of whether atrial remodeling plays a part. The duration of atrial fibrillation prior to ablation and in the early post-ablation period may be relevant, giving rise to the idea that suppressing the early recurrences will improve long-term prognosis. There have already been several trials that have examined this possibility, the earliest of which was the so-called 5A trial, antiarrhythmics after ablation of atrial fibrillation. The left panel demonstrates that antiarrhythmic drugs, in this case almost all class 1 antiarrhythmic drugs, led to a reduction in the recurrence of atrial arrhythmias in the first 6 weeks following ablation. And yet in the longer term, by 6 months, there was no significant difference between those who had recurrences of atrial fibrillation and other atrial tachyarrhythmias, depending on whether they were treated with antiarrhythmic agents. A trial which was presented at the ESC last year during the hotline was AMIO-CAT. This trial also explored the same hypothesis, but on this occasion with amiodarone. Again, you can see that treatment with amiodarone early following ablation resulted in a reduction of early recurrences, and yet, by 6 months, there was no statistically significant difference in the incidence of atrial fibrillation. It's worth noting that although atrial fibrillation begets atrial fibrillation in animal models, it has not been shown in humans that sinus rhythm begets sinus rhythm. Turning now to the ATP guided ablation that was presented. This depends on the electrophysiological effects of adenosine, as illustrated here from a publication by Datino from Nattel's laboratory. It rests on the basis of the fact that the atrial membrane potential, particularly the atrial myocardial sleeve around the pulmonary veins, is hyperpolarized. This hyperpolarization leads to an increase in the rate of upstroke of the action potential and a shortening of the action potential duration. All of these electrophysiological effects are greater in the pulmonary veins than in the left atrium itself, but lead to the uncovering dormant conduction or reconnection of the pulmonary veins to the atrium. There have been many previous studies that have explored the use of adenosine or ATP in patients post-ablation to guide the need for further ablation. In this meta-analysis published in 2013, there is a summary of the trial results so far. In patients, for example, who had adenosine testing and reconnection or dormant conduction was discovered, there was a tendency towards more recurrences and less freedom from atrial fibrillation than in those who had no dormant conduction or reconnection. On the other hand, on the right-hand side, we can see 3 studies in which patients who had reconnection either had a subsequent attempt to provide insulation of the pulmonary veins from the atrium or not, and here we can see a 25% increase in the freedom from atrial fibrillation if reconnection was destroyed. Just a few weeks ago in The Lancet, the ADVICE study was published. This again was an adenosine-guided pulmonary vein isolation procedure. There were some 534 patients, of whom 284 were demonstrated to have resumption of pulmonary vein to left atrium conduction following adenosine. These patients were then randomized to receive further ablation or not. There was a separate registry group of patients who had no reconnection, and they were also followed within the trial. It can be seen from the Kaplan-Meier's following the blanking period that those patients who had a reconnection that was revealed by ATP and subsequently ablated had the best prognosis with regard to freedom from subsequent atrial fibrillation, and those in the registry had an intermediate prognosis, and those, of course, had no dormant conduction discovered. So it behoves us to compare the ADVICE trial and the under-ATP trial. They are very similar, but of course there are some differences, notably that under-ATP took part in Japan. It used adenosine triphosphate. It was a mixture of atrial fibrillation types. It was not only pulmonary vein isolation, but other ablation procedures as well. On the other hand, the paroxysmal atrial fibrillation subgroup had a similar result to the group as a whole. It's unclear how successful the ATP-guided ablation was, particularly in under ATP, and the investigators may be able to tell us this. Of course, the lack of continuous monitoring is a problem in all trials of this nature unless patients are fitted with implantable continuous monitoring. I'd like to conclude, Mr. Chairman, by congratulating once again the investigators on this large and well-planned and executed study. I would like to confirm that EST-F definitely showed similar results to other trials of this nature, for example, 5A and AMIO-CAT, but the under-ATP results are not predicted by the meta-analysis of previous studies or the recently published ADVICE trial, and it is unclear to me whether methodological differences between the trials can explain this discrepancy. Thank you.
Thank you, John. We have time for one or maximum two questions from the panel.
Yeah, first of all, I would also like to congratulate you to this very important and very well executed, big, huge study. It is interesting to see that, as John Camm has pointed out, you did not observe any benefit with respect to rhythm outcome in the group that underwent ATP testing. And I think the most important reason for the difference to previously reported trials may be the patient population that you included persistent patient and maybe even long-standing persistent patient where the ATP test may not be of that significant as compared to paroxysmal atrial fibrillation, since other drivers for atrial fibrillation may be more important that are less susceptible for ATP testing. What is your opinion on that?
Thank you very much. I think it's a very big differences also. But in our data of subgroups divided to type of F, there were no differences also to subgroups. So it's a very good point, but not essential, or I think so. Also, there is another point of differences, including the waiting time and uses like irrigation catheter and diffractabilities like that for creating a durable PV isolation lesion is a very high use in this study. It's a very rational of the differences. And also, as you know, there is some report from recent report is with new technology with like a contact force catheter, like a cryo-balloon catheter. It showed very low recurrence of by ATP test. So I think technology and other factor will impact more effect of this phenomenon. Thank you.
Thank you very much, Dr. Kobori and Dr. Kaitani and Dr. Camm. We'll move on to our next presentation. which is from the BELIEF study. I'd like to invite Dr. Biase to come to the podium to present the effect of empirical left atrial appendage isolation on long-term procedure outcome in patients with long-standing persistent atrial fibrillation undergoing catheter ablation.
Mr. Chairman, colleague, I'm glad to present the result of this trial on behalf of all co-authors and the principal investigator, Dr. Andrea Natale. These are my disclosures. So as we know, long-standing persistent atrial fibrillation is the most challenging type of atrial fibrillation to treat with catheter ablation. If we look at the literature, the results after one procedure and even after multiple procedures is very poor when limited to the isolation of the pulmonary vein alone. Several studies have also shown that in addition to pulmonary vein isolation, other non-PV areas may be the source of initiation and maintenance of atrial fibrillation. Most of them are considered the superior vena cava, the ligament of Marshall, the coronary sinus, the cristae terminalis, posterior wall, and probably the left atrial appendage. In 2010, we reported the left atrial appendage as an underreported trigger site of atrial fibrillation in a population of patients that had recurrent atrial fibrillation despite isolated pulmonary veins. And in that trial, we found that 20% of the patients had firing from the left atrial appendage. So we decided after that, many other evidence of left atrial appendage as a trigger for atrial fibrillation were reported. This is localized reentry by the group of Isegger, other group here with the elimination of the appendage going to sinus rhythm, and the recently LALA-AF registry. So therefore, we sought to assess whether in patients with long-standing persistent atrial fibrillation, the empirical isolation of the left atrial appendage, in addition to an extensive PV antrum and trigger ablation, could improve freedom from atrial fibrillation, atrial tachycardia at follow-up in a multi-center randomized trial. And this was empirically done as we empirically isolate 4 veins nowadays. So this was a randomized parallel group study assessing this with the power calculation that was performed. 170 patients were enrolled and randomly assigned to an extensive ablation plus empirical electrical isolation of the appendage versus the extended PV antrum and non-PV trigger ablation. Inclusion criteria were patients with long-standing persistent atrial fibrillation with, or refractory to antiarrhythmic drugs. So this is the study design, 173 patients with long-standing persistent atrial fibrillation. As I described before, 85 patients in this arm, 88 patients in this arm. They were followed up, and the success rate was calculated at 12 months. After this, a second or a third procedure was allowed. In all the repeat procedure, left atrial appendage isolation was performed, and the outcome were assessed at 24 months follow-up. So primary endpoint was freedom from atrial fibrillation. Secondary endpoint were post-ablation hospitalization due to heart failure and or arrhythmia-related causes, mortality, incidence of stroke. Baseline and major clinical characteristics were no difference between groups. There was an increased radiofrequency time in the group that performed appendage isolation, no statistical difference into fluoroscopy and procedural time. In group 1, where the appendage had to be isolated, could not be isolated in AVL patients due to technical difficulties, although an extensive ablation was performed and the appendage was delayed. In group 2, in 32 patients, showed a firing from the left atrial appendage during the isoproterenol test that we utilized to look for that, while a sustained arrhythmias was observed only in 8 patients, 9% of the patient population, while in the remaining patients, non-sustained arrhythmias were found and the fire was ignored. This is the major baseline characteristics of the 2 groups. I would like to focus on the CHART score more than 2 or equal to 2 in 45% of the patients. Results. No patients were lost at follow-up. These are the results. I will show you the Kaplan-Meier maybe are better. This is the single procedure success rate at the 12 months follow-up. 56% in the group where the appendage was empirically isolated, and 28% in the group where the appendage was not electrically isolated. When cumulative procedure was performed, after 1.3 procedures, the success rate went up to 76% in the group where the appendage was isolated, and increased to 56% in the group that did an appendage isolation during the repeat procedures. Again, during repeat procedures, all patients underwent a left atrial appendage isolation, and this was statistically significant. After adjusting for age, gender, LA diameter in a multivariate model, isolation of the left atrial appendage was associated with a 55% reduction in the overall recurrence. Importantly, all patients performed a 6-month follow-up TEE, and these are the outcomes that were collected after a single procedure. Patient undergoing left atrial appendage isolation received TEE at 6 months follow-up. A low peak flow velocity, less than 0.4 milliseconds, was found in 48 patients. And in this patient population, one thrombus, in a patient that was with subtherapeutic INR was found. So when looking at this result better, we have between group 1 and group 2, 93 patients that underwent an appendage isolation. In 48%, the left atrial function was considered within normal range, while in 52%, the appendage was considered without a normal range for the presence of inconsistent A wave, for the presence of a low flow velocity, or for the combination of these two. This is an example here of an appendage pre- and post-ablation that we have considered within normal range, while this is an example of an appendage which has a low flow velocity after electrical isolation. This is the distribution of the anticoagulation regimen in this patient that stayed anticoagulated after the appendage isolation. These instead are the results of the AF-related hospitalization and the HF-related hospitalization. No statistical difference between the two groups. When looking at stroke or TIA, no stroke or TIA was reported in the group that had empirical left atrial appendage isolation. 4 patients had a stroke instead in the other group, and none of them had an appendage isolation. Importantly, this stroke happened because of low compliance to the anticoagulation following the ablation. No deaths occurred during the study period. Complication, 1 pericardial effusion occurred in each group and was treated conservatively with pericardial drainage. 1 gastrointestinal bleeding was reported in group that performed no appendage isolation. So just a comment before the conclusion is that why we believe this is important, because we believe that when the atrial fibrillation progresses from a paroxysmal to a persistent, to a long-standing persistent form, the relevance of the PV as a trigger of atrial fibrillation is reduced, and the relevance of other non-PV trigger area, which are not lines, which are not cafe, are relevant from atrial fibrillation. And in patients with long-standing persistent atrial fibrillation, we do believe that the left atrial appendage play a major role. So in conclusion, Mr. Chairman and colleagues, the results of this randomized study show that both after a single and redo procedures in patients with long-standing persistent atrial fibrillation, the empirical electrical isolation of the left atrial appendage improved the long-term freedom from atrial arrhythmias without increasing complications. Of course, future studies examining the physiopathology of these findings are necessary. Thank you very much for your attention.
Thank you, Dr. Biase. Now we'll call upon Dr. Hindricks from Leipzig, who will be the discussant for the BELIEF study.
Dear Luigi, dear colleagues, ladies and gentlemen, first of all, I would like to congratulate Dr. Biase and colleagues for conducting this prospective randomized multicenter trial in the important field of catheter ablation of long-standing persistent atrial fibrillation. It's particularly difficult and a big, huge challenge to conduct these trials and to terminate these trials successfully. I would like to roll out a little bit the background for the BELIEVE trial. Catheter ablation of long-standing persistent atrial fibrillation is the most complex procedure in the field that, as Dr. Biase has pointed out, goes along with a high recurrence rate and a lot of re-procedures necessary in order to maintain a high sinus rhythm rate in patients undergoing these procedures. And the results, as Dr. Biase has pointed out, are by far less good as compared to paroxysmal atrial fibrillation. So it truly makes sense to go into the field to explore whether additional ablation procedures to pulmonary vein isolation may be helpful and beneficial for the patient to achieve better outcome. Pulmonary vein isolation is the cornerstone of therapy for persistent and long-standing persistent catheter ablation of atrial fibrillation. And it is interesting that recently the trial from Atul Verma has shown that in patients with persistent atrial fibrillation, additional ablation with linear lesions and or ablation of complex fractionated electrograms does not add any significant benefit as compared to pulmonary vein isolation alone. Having this in mind, it's particularly interesting to follow the results of the BELIEVE trial, as this trial explored the feasibility of additional lesion sets in order to improve outcome. The effects of left atrial isolation in addition to PVI have never been investigated before in a prospective randomized fashions, and the key questions to the study is, does this procedure add benefits with respect to rhythm outcome, and is there any impact on complications with additional ablation in this delicate structure of the left atrial appendage? The main results of the BELIEVE trial, in my opinion, are the following. First of all, the trial shows that left atrial appendage isolation can be successfully achieved by catheter ablation in the majority of patients. With left atrial appendage isolation, the procedure duration and radiofrequency ablation time significantly increases. However, this does not result, and this is a good part of the results of the study, in an increased complication rate as reported by Dr. Biase. The recurrence rate of atrial fibrillation was significantly lower in patients that underwent left atrial appendage isolation as compared to PVI alone. And also, and this is really striking to me, there was a very, very high stroke rate during the follow-up period that is difficult for me to explain in the control group. What are the main questions that I have to the BELIEVE trial? First of all, a remark. I think it would have strengthened the study results if LAA isolation would have been consistently not performed in the control group, regardless of the electrophysiological behavior of the left atrial appendage in the first catheter ablation session. What was surprising to me was that the dynamics of arrhythmia recurrence observed in this study is unusual, as there was obviously no difference in the arrhythmia recurrence between both groups after the blanking period within the first 6 months. And this is something which is really unusual, as it has not been observed in many, many previous studies when you have the recurrence early after the blanking period, and early recurrence predicts late recurrence. So it's really unusual that in the first 9 months, 6 months after the blanking period, there was no difference. And I have problems to understand that and to explain it. Left ventricular function obviously was not impaired in 48% of the patients in the LAA isolation group. I do not fully understand how that does fit to complete isolation. In my understanding, I would have expected a more significant impairment of left atrial appendage contraction after complete isolation. In the patients that we isolated at Heart Center Leipzig, in the majority, you have complete standstill after complete isolation. And I would also be interested in exploring a little bit more in depth what was the impact of the non-isolated left atrial appendages due to procedural failure or due to reconduction. We see reconduction in the pulmonary veins. We should also see reconduction in patients undergoing left atrial appendage isolation. Why was the stroke rate in patients not undergoing LAA isolation so unusually high, 4.5%? Luigi Di Biase belongs to the group of Andrea Natale that has shown in previous studies a stroke rate post-ablation almost below 1%, almost zero. And it's really surprising to me to see such a significant stroke rate, despite the fact that the anticoagulation regimen was well executed in both patient groups. There are some controversial observations to the BELIEF trial. The Hamburg group von Karl-Heinz Cook has reported a very high rate of thrombus formation and of stroke following left atrial appendage isolation, and it's not quite clear to me why the results are so divergent from the BELIEF trial. The Hamburg group has reported 50 patients that underwent left atrial appendage isolation as a result of PVI plus additional ablation procedures. In this patient cohort, 21% of the patients that had isolated appendages actually had a thrombus, and three of the patients developed stroke during a follow-up. In that particular study, no stroke occurred in a matched control group matched to the patient that underwent left atrial appendage isolation. So my final thoughts for the trial is the results from this prospective randomized multicenter trial are interesting and important as they add new information about the potential role of left atrial appendage triggers in patients with long-standing persistent atrial fibrillation. Overall, I consider the trial hypothesis generating rather than fully convincing due to the methodological limitations of the study that I see. The dynamics of arrhythmia recurrence and the stroke rate observed in the control arm are difficult to be explained to me and need further careful discussions. And the question is, should LAA isolation on the basis of the BELIEF trial be recommended as an integral part of catheter ablation of long-standing persistent atrial fibrillation? No, I believe further studies are necessary before such recommendation. Thank you very much for your attention.
Thank you, Dr. Hindricks. We've got 4 minutes for the panel discussion, and may I suggest that we just focus on one aspect for the moment. I'm going to ask Dr. Lundqvist first about the question she has, but I hope we can talk about anticoagulation over the long term here.
I was going to ask you whether you would expect that if you use the cryo balloon in the ablation procedure, would you have any difference with an isolation of the left atrial appendage in that case? And the reason I'm asking is because the ridge between the left atrium and the appendage is quite sometimes very difficult to isolate. So the effect may be that you are going there a second time and delivering your RF energy. So in that way, you have a better effect rather than the isolation of the appendage itself.
Thank you for the questions. Well, this appendage isolation was performed using radiofrequency point-by-point energy. I have no experience in performing appendage isolation with the cryo energy. It's a good hypothesis. I don't know if it's safe and feasible to do that. I think it should be possible because I have some animal experience with that, but we haven't done it. I have no experience. I have no clinical data to answer to you. I would like instead to answer two comments to yes. Dr. Hindricks, if I can. So he mentioned the STAR AF2 trial. I would like to say that this was in patients with persistent atrial fibrillation, non-long-standing persistent atrial fibrillation, that the relevance of PVI better than line and café is shown in the Kaplan-Meier here, but with a follow-up of only 9 months, no more than 9 months. After 9 months, the success rate here is 55% for all these 3 groups. I believe that if extending this to other non-PV triggers, which may include the appendage, they would have been better, or at least this is our experience. In regards to the type of recurrence, why they happen after 6 months, well, the appendage, as was underlined, has a high recurrence rate, more than PV, due to the thickness of its structure. So it takes maybe some time to reconnect. And in the patient where that did not undergo appendage isolation empirically, they still underwent an extensive ablation, which include the coronary sinus, the superior vena cava, and the posterior wall. So the fact that for 6 months they did not have recurrence or had recurrence later is explained by the fact that this patient did not undergo just PVI alone, but underwent an extensive ablation procedure. And this is my personal reply. In regards to the 4-stroke, as I mentioned, these are 4 patients that occurred during follow-up. It's a randomized trial, and all 4 patients had low compliance to warfarin. This happened during, so this point out a good point. If the appendage have an increased risk of TIA stroke, we need to recommend a very compliant anticoagulation. This is a limitation of the study, although today we have closure device, and this may be a potential additional piece of a future study.
A very quick answer, Dr. Lip. Given the totality of all the information that you've heard, including the mechanical function here and the Hamburg data, are you prepared to stop oral anticoagulation if, in fact, the patient does have this additional left atrial electrical isolation?
A very short answer is no, because ultimately we are dealing with a progressive disease. There is multi-morbidities. I would certainly like to see larger studies with evidence to see how much the mechanical function is depressed and how long it is depressed for, and whether there is any return at all of mechanical function. But ultimately, it's risk factors that drive the stroke risk.
And I would like to add a point here. These are patients with long-standing persistent atrial fibrillation. 45% of the patient population had a CHOT more than 2, which by guidelines and European guidelines, even after a successful ablation, cannot stop anticoagulation. So these are patients that are doing an ablation to benefit from sinus rhythm and not to discontinue anticoagulation. This is an important message to give.
Thank you very much. We have to move on to the next presentation. Assessment of an education and guidance program for apixaban adherence in non-valvular atrial fibrillation, the randomized IGN study by Dr. Montalescot from Paris, France.
Mr. Chairman, ladies and gentlemen, it is a pleasure and a privilege on behalf of the steering committee members to present the results of the IGN study. A few words of background. Vitamin K antagonists have several drawbacks, including the need for frequent anticoagulation monitoring and dose adjustments. And the NOACs, non-vitamin K oral anticoagulants, have overcome many of the drawbacks, including this need for frequent anticoagulation monitoring. However, we may wonder if adherence to NOACs is good, knowing that these patients do not have anticoagulation monitoring and do not go to the anticoagulant clinics. So we wanted to evaluate the impact of a proactive educational program on adherence to anticoagulation therapy for stroke prevention in atrial fibrillation using here apixaban. There are 3 phases of adherence to treatment which have been defined. The first phase is initiation, when the first dose of the medication is taken. And it is often in the hospital, and it's not a big issue for adherence. The second phase is implementation. And this is when the patient is outside of the hospital, and this is the extent to which a patient's actual dosing corresponds to the exact prescribed dosing. And this is exactly what we wanted to evaluate in the aging study. The third phase is persistence, and it relates to discontinuation of treatment. And this is what you see usually in the reports of the big clinical trials in atrial fibrillation. And we have looked at persistence also in this study. The primary objective of the AGN study was to assess the impact of an educational program on implementation phase adherence in patients taking apixaban for atrial fibrillation. And this was assessed at 24 weeks. And we used an electronic monitoring device to measure adherence. There was a list of secondary objectives. Among them, we wanted to assess the impact of this program on persistence at 24 weeks. We wanted to identify the predictive factors of non-adherence in our patients, and we wished to evaluate efficacy and safety of apixaban in this study, looking also at clinical events. So the design of the study is pretty simple. We recruited atrial fibrillation patients requiring anticoagulation, and we randomized these patients to apixaban with the usual standard of care, or we randomized these patients to apixaban with an additional educational program. And this additional educational program included booklets explaining the disease, explaining the treatment, explaining the symptoms of stroke to the patients, included reminder tools given to the patients, keyrings, SMS, smartphone applications, but most importantly, included contacts with the anticoagulant clinics which have been developed in the 6 participating countries to monitor patients on warfarin treatment. So we used these clinics and the personnel to be in contact with the patients, to educate the patients, to inform the patients. The clinics called the patients, and the patients could call the clinic, and that's how the patients were informed and educated. There is a second phase of this study, which is represented here. At 6 months, these patients in the educational program were re-randomized for interruption of this program or for continuation of the program. This phase of the study is still ongoing, and no data will be presented about this second phase of the study. We will have to wait 1 more year for this. So the hypothesis, of course, is that the patient adherence is enhanced with this educational program, and that treatment persistence is also increased with all the tools we provided to the patients. The study had 85% power to detect a between group difference of 4% in the percentage of days with a correct execution of the dosing regimen during 24 weeks, assuming an intragroup standard deviation of 21% coming from the in-range study. So we needed 1,100 patients, and we recruited a little more than 1,100 patients for this study. The key inclusion criteria are very simple. Patients with atrial fibrillation, a CHAD score of 1 or more, and these patients could be on vitamin K antagonist or not at the time of selection, and they could be also on aspirin for various reasons. We had a list of exclusion criteria in this study: high risk of bleeding, inability to self-administer the study medication, and of course patients who were hospitalized could not participate to the study. Adherence to twice daily apixaban during this implementation phase had stringent definitions. A day of adherence typically was a 24-hour window during which apixaban was taken twice daily as prescribed. if only one tablet was missed in isolation, so the drug was taken well the day before and the day after, it was considered to be a day of adherence. A day of non-adherence was the same 24-hour window with 2 consecutive tablets within 24 hours which were missed, or 1 tablet missed for several days with various scenarios for this situation. We defined persistence as the absence of permanent discontinuation, and that was a secondary endpoint of the study. We used an electronic monitoring device, which is represented here, and you can see the blister inside this device. So each time the patient wanted to take a pill, it was indicated, and the date and hour of intake was recorded in this device. So let me show you the results of this study. You have a selection of the baseline characteristics here on this slide, and there were no differences between the 2 groups. Mean age was 72 years. We had all types of atrial fibrillations. We had a chart score on average of 2.1. We had a majority of patients vitamin Ka naive at the time of randomization. We had 20% of patients on aspirin when they were selected, and the vast majority of patients took the high dose of apixaban 5 milligrams. This is a primary endpoint, and as you can see, there was no impact whatsoever of the educational program on this primary endpoint. But most importantly, we had high rates of adherence in this study, 94% at week 4, 92% at week 12, 88% at week 24, of course, leaving little room for improvement with this educational program. It's exactly the same when we looked at persistence. So now we are looking at these patients who discontinued treatment during the 6-month period. And again, there was no impact of the educational program on persistence. But again, high rates of persistence, 91% on average in both groups. We looked at the pre-specified subgroups of this study for adherence at 24 weeks, and the data were very consistent across all these subgroups, except maybe for these patients with a prior history of stroke, although, of course, these analyses have not been adjusted, and the interaction was not very strong. We examined the possibility of having predictors of non-adherence, and that would be very useful for clinical practice. But we were disappointed and were unable to identify a strong predictive factor of non-adherence in this study. Clinical outcomes are going along the same line. You have these clinical events which were all adjudicated here. There's 4 events for standard of care, 6 events for the educational program, stroke, TIA, or systemic embolism, if anything, numerically speaking, slightly more events in the program of education. Myocardial infarction, no difference. Major bleeding, no difference. AGN has limitations, of course. There was a selection of the patients which may not fully represent the real life of patients with atrial fibrillation. Second point, measuring adherence increases per se adherence because the patient is aware of it. This effect was minimized because neither the patient nor the investigator was aware of the adherence data during the course of the trial. All measures of adherence tend to overestimate the real adherence of the patient to a medication. However, we use this electronic monitoring device that precisely recorded day and time of medication access. And the last point, adherence may decrease over time, and 6 months may be seen as a short period. But this is now the second phase of the IGN study, and we will reconvene at 1 year to see if we have the same kind of results. So in conclusion, The study shows a high adherence rate, 88%, in the first 6 months of apixaban given twice daily for the treatment of atrial fibrillation, and a high persistence rate, 91%, in the first 6 months of treatment. There was no additional value of a proactive additional educational program on adherence in the first 6 months of treatment. Long-term adherence, as well as the value of an educational program beyond 6 months, will be further evaluated in the second part of the IGN study. I would like to thank all the investigators in the 6 countries which participated to the study. It has been a difficult study to conduct, and few patients were recruited per center because it was difficult to conduct. But thank you to everyone.
Thank you very much. I'm asking Dr. Greg Lip to discuss the IGN trial.
Mr. Chairman, ladies and gentlemen, firstly, my warmest congratulations to the IGN investigators for conducting this very important trial. And as I will highlight in my presentation, firstly, starting with the general principles, this is actually addressing a very topical and timely area with regard to providing thromboprophylaxis for stroke prevention in atrial fibrillation. I would then, as part of my discussion, then focus on a few slides on the specific aspects. But the first bit is to highlight the general concepts in this area, which makes this trial an important one, a topical one, and highly relevant to our practice for managing AF patients. For starters, I wish to show my declarations of interest. That's the short version. And just to give you the long version, where just be aware that I have membership of guidelines and reviewing and steering committee and trials, as well as editorial roles, consultancy, advisory, and speaker. And please bear in mind, whatever I say today has to be taken into context what I declare on this slide. By way of introduction, why do I say as a general concept, this is topical, this is important? As you can see from the slide, ERA, the European Heart Rhythm Association, published earlier this year a position document looking at cardiac arrhythmias and patient values and preferences. After all, most of us, all of us looking after patients, we are looking after patients. Patients are, in a sense, our customers. They are central to our everyday clinical practice. Patient values and preferences and understanding why they do take medications, understanding their values, understanding why they continue with therapy is part of holistic management of atrial fibrillation. But what do older data tell us? Well, we've known for quite a long time that warfarin has been a difficult drug to manage when provided as stroke prevention in atrial fibrillation. And for that matter, aspirin is no more benign either. And these are old data, as you can see, from 2008, where very clearly showing that in relation to time since starting treatment, there's a very clear attrition in the patients continuing or persisting with warfarin therapy, and ditto the same with aspirin therapy. There's a small age gradation, and there's a small relationship to risk score with a CHAD score here. But you will see the main attrition is clearly seen in the long term, and I'm really looking forward to the long-term aspects of AEGEAN to see how the intervention helps with long-term persistence and adherence to therapy. The next concept I would make in relation to a general point, what we are aware is with the non-vitamin K antagonists, anticoagulants, the NOACs, all these drugs have a moderate half-life. And if the patients are not adhering to therapy, we are starting to see real-world data how these things can actually, non-adherence to therapy can translate to bad outcomes. And I'll show you one example. This is from the Veterans Health Study. This was over 5,000 patients, and 28% had poor adherence, but importantly, this translated to about a 13% excess in mortality and stroke. So as a concept, understanding adherence and persistence is very important. This is all the more so important for NOACs. In a sense, we have with the Aegean trial, it would not be powered to look specifically a lot into the detail of outcomes, but I think it's important if such an analysis could be extended to try and look at this in bigger data sets as well. Patient values and preferences. What do I mean by that? Well, it's actually trying to engage patients in treatment decisions about their health and understanding their feelings and beliefs on the subject. This gives health professionals an opportunity to address concerns about medications, correct misconceptions, increase patient knowledge about atrial fibrillation and their therapeutic options, will help patients make informed decisions about their healthcare, make them cognizant about the consequences of action or inaction about accepting antithrombotic therapy for stroke prevention, atrial fibrillation. There's the hope, therefore, that such an engagement will improve adherence with treatment. And as we can see from the Aegean trial, at least in the short term, we didn't manage to see that. So we maybe have to think about our last statement here. Nonetheless, we are dealing with atrial fibrillation. These patients are elderly, they have lots of comorbidities, and perhaps it may well be more difficult to see the incremental effect on an educational program, given that many of these patients, because of their comorbidities, already regularly attend for follow-up. And let me give you an example why I say that. This is an analysis from the Danish nationwide cohort study. And what we saw here was, and it's a large numbers of patients, and what we did see here, there was a relationship of adherence to higher CHA2DS2-VASc score. So in other words, the fact that they had associated comorbidities, they're going to be attending more regularly for follow-up and treatment and blood pressure control and that sort of thing. And you may well have had the challenge of trying to see the incremental benefit of an educational program on top of it. So the next thing to mention is what are the data, at least from surrogate aspects of adherence and compliance. These are data from the TREAT study. This is a randomized patients on warfarin randomized to usual care or an educational intervention. What we did see in the TREAT trial, if you look at TTR, time in therapeutic range, as a measure of anticoagulant control, educational intervention did show a significant difference at the 6 months. There was a trend at the 12 months, but we lost statistical significance. So, as mentioned, I'm looking forward to the longer-term analyses from the Aegean trial and see whether how you may show something opposite to what was seen in the TREAT trial. So turning to Aegean, a few specifics. I think it's actually, as you've seen the slide on the investigator presentation, but I want to flag up that for the primary objective of assessing the impact of the educational program on implementation in relation to adherence on apixaban was very impressive, 88%. They may well not have been seen the difference in regard to the intervention, but a high adherence is evident, and to show the incremental on top of that may be a bit tough. The next thing, therefore, is the secondary objective, the persistence at 24 weeks. Well, looking at persistence, again, you've seen the slide. It suggests that the educational intervention did not make a difference. But look here, we already have a high persistence, around 91%, to show the incremental benefit may be a bit tough. And just to conclude, this is also an important trial. As I mentioned, it addresses a very contemporary topic, highly topical now in relation to our approach to patients with AF. It is the first large prospective randomized trial of an educational intervention on adherence and persistence to NOACs. There was also a very high rate of adherence and persistence overall on apixaban, and that is commendable. Some of the limitations have been discussed, patient selection, and again, because they are in the trial, as is how reflective of real-life patients. Measuring adherence, the patients know they're in a trial, so they are going to be more aware, may well be increasing their adherence. The comorbidities and the regular healthcare professional contact may well have influenced the results. The trial is not quite powered for efficacy and safety endpoints, and I'm looking forward to seeing the long-term data. Thank you.
So we have time for one very short question from the panel.
Gilles, did you do any kind of sensitivity analysis with regard to the endpoint? You used a variety of endpoints in this study, and I understood why you did that. But to some extent, we're really concerned about patients who miss not perhaps just one day, but 2 days or 3 days in a row. That kind of adherence pattern may be much more relevant than simply dropping a pill or dropping 2 in a row. Did you do any exploration of that kind?
Yes, we looked at the number of pills missed per patient. On average, it was 1.6 in this trial over 6 months. Of course, it will be more at 1 year. I'm sure of that. We will see what it is. Now, we try to identify a profile of non-adherent patients, and we had difficulties and did not have a typical profile. Alcohol seems to be a little bit associated with poor adherence, but nothing else.
Thank you both very much. We'll move on to our last trial here. That's going to be presented by Dr. Reddy. The safety and efficacy of a leadless pacemaker results from the leadless 2 clinical trial.
Thank you very much. So it's my pleasure to present this, the leadless 2 trial on behalf of my colleagues, the other members of the steering committee, and the other investigators. I should note that I do have a conflict of interest. I received grant support and served as a consultant to St. Jude Medical, the manufacturer of this particular leadless pacemaker. I will also be discussing the use of a non-FDA approved device. This leadless pacemaker is not approved in the United States. Also, I should note that the subject of this presentation has actually been published in a manuscript in the New England Journal of Medicine. It went online this morning, so for any slides that I skip, you can actually access that information in the journal article. So I should start off by acknowledging that pacemakers, standard pacemakers, are a highly mature technology and overall are quite reliable devices. Yet they still include the generator, the connector, and the lead. And the implantation necessitates both the surgical pocket as well as the transvenous leads that are in the vasculature. And this leads to several issues. Certainly, the device can lead to discomfort, hematomas can lead to infection, infection can lead to erosion, and of course, there are cosmetic concerns. Probably more substantial are the lead complications that can occur. Leads can become damaged, they can have lead fractures resulting in failure to capture, failure to sense, and they can get infected, and extraction can sometimes be a harrowing experience. Also importantly, leads can act as antennas in the setting of an MR imaging and can lead to heating, thus making compatibility with MR imaging problematic. Now, how often do these complications really occur? Well, I think most of us believe that pacemakers, since we've done this for many decades, are relatively safe procedures, and that is true. However, complications do occur. And this is a relatively recent study, the FollowPace study, which included almost over 1,500 patients receiving pacemakers, single-chamber and dual-chamber pacemakers. And there was a substantial incidence of complications. If you look at this Kaplan-Meier curve, what you see is over the first 2 months, there was a 12.4% rate of complications. And there's a subsequent almost 10% rate of complications over the lifetime of, at least over the subsequent 6, 7, 8 years. Now, this is a very difficult to read table, but I just want to go through a few aspects. First, if you look at traumatic complications, and these are the earlier within 2-month complications, and these are the late complications. The tamponade rate was about 0.5%, but there was a pneumothorax rate of about 2.2%, giving an overall traumatic complication rate of 2.77% early. If you look at lead-related complications, and this includes certainly early lead dislocations, you see a 5.5% complication, which is again matched in late follow-up, again 5.5%. There are pocket complications, including hematomas, and 2.9%, leading to an overall acute complication of 4.75%, including long-term complications. And there are also pulse-generated complications related to the device reliability. So overall, the data tells us that the percent of patients that require reoperation because of complications is 4.2% early and 4.0% late, ultimately leading to an overall complication rate of 12.4% acutely and 9.2% chronically. So can we avoid both the surgery and the lead? And the concept of a fully self-contained pacemaker is not a new concept. This is a paper published almost a half a century ago. And our current device, a device that's actually able to perform this in a reliable manner, is called the nanostim device. This device, which is the subject of this Lelis 2 study, is approximately 4 centimeters long, 6 millimeters wide, can be delivered through an 8 French introducer in the femoral vein. The device is fully self-contained, so the battery, the electronics, and the pacing element are all within this particular device. Because there is no lead, at least in theory, this device is inherently MR compatible. It does have many of the features that we see in conventional pacemakers, albeit not all features. It does have the ability to be rate responsive, a battery life that's substantial, and I'll talk more to this, hysteresis and magnet modes. And you can see the back of the device has this nub, which actually can be used to actually retrieve the device, and I'll show you some data to that. And here's an example of the device placed in the right ventricular apex. The device is delivered through a catheter, so there's a deflectable catheter to which the device is affixed to the end, and then the device is actually delivered. And here's just a cartoon that describes the implantation of the device. So the device is introduced through the femoral vein. There's a protective sleeve over the helix to protect it. Then the device is advanced into the right ventricle. Once the device is known to be touching the wall, then the whole catheter is rotated to allow the device to actually engage the tissue. There's a marker on fluoroscopy that allows the operator to realize how well they're attached. If it's not a good position, it can be unrotated, or it can be rotated in the other direction, repositioned, and put in a different location. Once it's in good position, then the device is released. Here it's still tethered. If it's in a good position, then it's ultimately released, and hence the device is deployed. Here's just an example. This is an RAO view showing the device was in the right ventricle. And here you see a rotational angiogram. And you see the device just off the septum in this particular patient. This device was first studied in a first-in-man study, a small study, 3 centers, 33 patients that we published about a year and a half ago. I should note there's another device called the micro device, which is also being studied. But this leads to the Lelis 2 trial. This is a very large, multi-center prospective trial. It is non-randomized. It is an FDA-ID study. The objective was to evaluate the clinical safety and efficacy of this nanostim pacemaker for non-surgical implantation in patients indicated for single-chamber ventricular pacing. There's a primary safety endpoint, which is freedom from serious adverse device effects, and primary efficacy endpoint, which is the combination of both acceptable pacing capture threshold as well as acceptable sensing amplitude by 6 months. The study was conducted in 56 centers in the US, Canada, and Australia, including a total of 100 operators. And I should note, only one of these 100 operators had prior experience with leadless pacing before entering the study. I want to go through some of the inclusion criteria. There are 3 main inclusion criteria: patients with chronic AFib who had high-grade block, resulting in slow ventricular rates with AFib. This constituted the majority of the patients. 56% of the patients enrolled in this trial had this indication. 8% were in sinus rhythm and had high-grade block with low level of physical activity. And the remaining patients had sinus bradycardia with infrequent pauses or unexplained syncope with EP findings. I'm not going to go through this slide. This is in the manuscript. Now let's go through the methodology and the endpoints. There were pre-specified primary efficacy and safety endpoints, which were designed to be analyzed in the first 300 patients after following them for 6 months, and that occurred in June 2015. That we define as the primary cohort, this 300 patients. There was a performance goal for the primary efficacy endpoint of 85% and a performance goal for the primary safety endpoint of 86%. The primary efficacy endpoint was assessed in both the intent to treat population, which is the primary analysis, as well as those patients who had a successful implant. The primary safety endpoint was assessed in the intent to treat population. I should note that in this 6-month of follow-up, an additional 226 patients were implanted. So this total 526 patients is the total cohort, which I'll also speak to, particularly for the safety data. And I should note that all adverse events were adjudicated by an independent clinical events committee. This is the patient flow. After the patient signed the informed consent and was enrolled, that defines their entering the intent to treat population. After implantation, the patients are followed at 2 weeks, 6 weeks, 3 months, 6 months, and every 6 months thereafter. This is the patient flow. There were 300 patients, again, constituting the primary cohort. of which 289 patients had successful implantation. The additional 226 patients plus the 300 patients gives us the 526 total cohort. These are the patient demographics, and what you see here again is the primary cohort and the total cohort. And you'll see that these numbers are very similar. The mean age was 76, so this is a trial of elderly patients. The BMI, mean BMI was 29 with a range from 15 to 60.3. 2/3 of the patients were male, and the patients were predominantly Caucasian and not Hispanic. The patients did have other comorbidities. 40% had coronary artery disease, 80% had hypertension, and diabetes in 27%. There was tricuspid valve regurgitation in about 1/5 of the patients. The mean ejection fraction was preserved in this population. You can see about 60% of the patients were taking oral anticoagulation, and 47% were taking antiplatelet therapy. These are the procedural characteristics. Overall, successful implantation was achieved in 96% of the patients. You can see the time for both the full procedure as well as just the delivery of the pacemaker itself. And there's the fluoroscopy duration, about 14 minutes. You can see that the majority of these patients, 70% of the patients, the device at the first location was acceptable, and the remaining patients, it had to be repositioned to a slightly different location. Not dissimilar to what we do with traditional pacemaker leads when they're not in a good position. About 48% of the patients, the device was placed at the apex, and the remaining was placed off the septum or in the outflow region. Here are the primary endpoints, the primary safety endpoint from the intent to treat analysis. 280 of the 300 patients achieved this endpoint. That's 93.3%. The lower confidence interval was 89.9%, which exceeded the performance goal of 86%. For the primary efficacy analysis, 270 of the 300 patients achieved the endpoint. This 90% again exceeded the performance goal. The lower confidence interval of 86% again exceeded the performance goal of 85%. And for those 289 patients who had a successful implant, at 6 months, 270 of these patients had adequate pacing and sensing, again showing 93% achieved this endpoint. So overall, all of the endpoints were achieved in this trial. Let's talk about the serious adverse events in this trial. There were a total of 6.5% serious adverse events. You can see the cardiac perforation occurred in 1.5% of the patients, some of whom required pericardial centesis, either surgical or catheter-based. Vascular complications occurred in 1.1%, mainly hematomas and other vascular complications. Device dislodgement occurred in 6 patients, 1.1%, and all of these, the device was percutaneously removed and a new device was placed. Device migration during the procedure, that is before the procedure was completed, occurred in 2 patients. Again, this was addressed with a new device. And elevated pacing thresholds occurred in 4 patients. These patients also had a new device placed. This is a Kaplan-Meier curve showing that after the first 2 weeks, there are really no safety events. So really the safety events occur within the first couple of weeks. Again, I should note the follow-up is only 6 months here. Same thing with the full cohort. These are just device electrical measurements, and I won't spend time on that. I do want to just talk for a minute about battery longevity. Depending on the percent pacing, this is the estimated longevity, anywhere between 8.8 to 18.9 years. What was actually observed, and by observed, I put this in quotes because we looked at the device use characteristics during the first 6 months and then projected what would be expected. And actually, the device longevity was estimated at 15 years. And the last point I want to make is retrievability. The device was able to be retrieved in 7 of the patients that received the device at a mean of 160 days, as far out as 413 days, successful in all of the patients. And this is just an example where the device is at the loop snare, either trilobe or a single loop, grabs the back of the device, and then the catheter engages the device to remove the device. So in conclusions, the observed safety and efficacy of the leadless pacemaker supports its use as an alternative to standard pacemakers in patients requiring single chamber ventricular pacing. The device was successfully implanted in 96% of the patients. The trial did meet the pre-specified safety and efficacy endpoints, and I do want to point out that the complication rate is likely to improve with operator experience. Remember that 99 of the 100 operators had never implanted this device before. The estimated device longevity is encouraging. There are some important limitations. This is an observational study. It's not a randomized study. The comparators to historical controls are at best hypothesis generating. The mean follow-up was only 6 months, so we really can't talk about what happens after battery depletion, what happens after 5, 10, or 15 years. The device does have limited diagnostics in terms of electrogram data, and it does use a larger sheet, though we did not see a very high rate of vascular complications. And importantly, this is a single chamber pacing device only. This addresses about 15 to 20% of all the patients who require pacemakers. Thank you very much.
Thank you, Dr. Reddy. I'll call upon Dr. Blomstrom-Lundqvist from Uppsala to discuss the Leadless 2 trial.
Thank you, Mr. Chairman. Ladies and gentlemen, it's my pleasure to discuss this very interesting study. As you've heard, the Leadless 2 trials, the purpose of the trial was to assess the safety and efficacy of this chamber device. And of importance is, of course, to know the equivalent or the superiority of the risk-to-benefit ratio of a suggested therapy versus an established therapy, which in this case is a single chamber lead pacemaker. But this study did not compare the new with established therapy in a randomized fashion. So I would like to go through with you the major limitations of the trial, and let's look at the patient selection bias. The study was non-randomized, as we've heard, so therefore the study may include patients at lower risk for efficacy and complications. There was not even an active concurrent control arm, only historical controls used, and they were not publicly available, so we couldn't have access to the patient that were compared with the patients receiving this new device. So there may be unobserved differences in patient characteristics. What do we know about the inclusion process? Were patients included prior to the surgical therapy or not? If not, one can expect that difficult cases or failed cases may not have been included in the trial and excluded. Did the trial have a logbook to monitor the excluded patients or not included patients? What was the procedure selection bias? Were the emergency implants? Were there any out-of-hours procedures? Well, these are procedures that have higher complication rates, and these rates that we have reported from registries have indeed included both emergency and out-of-hours procedure for the single-lead pacemakers. If we look at the centers participating in this trial, we can see that these are high-volume centers, mostly institutional centers, so there is probably a center selection bias. The first 300 patients analyzed were included for this analysis, and there is a risk that the centers with high volume actually did include the first 300 patients. So an explanation for the lower complication rate. Now, the main observation with a primary safety endpoint or 93.3%, again, not randomized and not directly compared with the VVI pacing. Intention to treat concept in a non-randomized study. I have some difficulties with that, because the primary safety endpoint is favored by an unsuccessful implant attempt, since devices-related adverse events will not develop in these patients. So I would prefer a safety analysis set instead of this intention to treat concept. The main observation with a 6 months follow-up of 6.7% of the patients, we can see if we look into detail that there were complications like device dislodgement, 1.7%, pacing thresholds elevations that required intervention, 9.3%, and cardiac perforation, 1.3%. And if we compare these complications with solid registries like the Danish one, which also included monitoring of the hospitals, we can see that the single chamber VVI pacing complications requiring a re-intervention was 1.2%. That is a little bit lower. So the comparison made by Dr. Reddy in previously was actually included also dual pacemakers. Cardiac perforation was also very unusual in the Danish trial, only 0.3%. So my take-home message from this trial, I think that we need to have a randomized trial to assess both the efficacy, safety, and to be able to say if this is a superior therapy or not. We also need larger registries and include consecutive patients. I guess that European patients have been implanted with the device, and we don't have those figures. So it's difficult to also draw any conclusions on safety with regard to the retrieval because of the small numbers. But nevertheless, this is a very new technique, and I congratulate you for the very nice study, which probably have great potentials for the future, maybe as an add-on to subcutaneous ICD for ATP therapy or CRT. Thank you.
Thank you very much. We have just a few minutes left for some comments from the panel.
Yeah, Vivek, congratulations to the successful termination of that important trial. I believe that leadless implants will provide a significant step into a new era in electrical device therapies and will provide significant benefits for the patients in the future. This is the first step in this consecutive patient series. I was impressed to see that you did not observe any complications after the initial phase. If you look to the concept of implantation of the devices, there are, by common sense, concerns like dislodgement during traumas or events like this. There was nothing observed in that respect in the trial?
Yeah, no, I think that, again, some things did happen within the first 2 weeks, but beyond that, we did not observe it. But again, with the caveat that the time horizon was 6 months. So we don't have 2 years, 6 years, 10 years. Having said that, look, I think the comments that were made were absolutely spot on in terms of this is not being a randomized trial. The flip side is that, you know, in a randomized trial, the advantage of this device is likely to be realized over time. So that's the point number one. And point number two, think about how many millions of pacemakers we've implanted, and our experience with leadless pacemakers is probably less than 1,000 at this point. So I think we're early. There are real complications. I'm not trying to minimize them, but it's still, I think, very promising.
I have one short additional question. Does the device implantation require oral anticoagulation in patients in sinus rhythm? In AF patients, according to Chetz-Vasco, it's quite easy, but in patients with sinus rhythm, do they need anticoagulation?
No. So in this device, in the majority of patients, the patients were not on anticoagulation, neither oral anticoagulants nor antiplatelet agents.
Right. Thank you very much. I'd like to thank all of the presenters and the discussants for a marvelous session, and that concludes Hotline Session 2. Thank you very much.
Marvelous.
Thanks.